The next session is HCC 7, Advancements in Radiation Therapy for Hepatocellular Carcinoma. The moderators are Professor Masaru Wakatsuki and Professor Hideyuki Sakurai. Professor Wakatsuki, please start.
Okay, we will now start HCC 7. We had planned for 4 speakers in this session, but we will proceed with 3 speakers and with Dr. Oki as a discussant. And in addition, the other moderator, Professor Sakurai, is overlapping with the moderator of another session, so I will be the sole moderator for this session. Okay, let's start. I'm the first speaker. Okay. Okay, I'm Masaru Wakatsuki from QST Hospital in Japan. I'm great honor to this great opportunity. Thank you for Professor Shina and the organization committees. Okay, my title is carbon therapy for hepatocellular carcinoma. I would like to introduce the carbon therapies. Okay, I have no COI. These are the particles used in radiation therapy. Among the charged particles, a proton is widely used in cancer therapy. But we use the carbon ions because the carbon beam can provide a very concentrated dose distribution to the cancer lesion and have higher biological effect. And the carbon beam has more obvious advantages than other particles on clinical use, which would result in improvement of therapeutic ratio in cancer therapy. There are 2 advantages. One is physical advantage on dose distribution based on the dose peak called black peak. Another one is biological advantages based on the dense ionization due to high linear energy transfer by heavy particles. And at present, there are 16 carbon ion therapy facilities in the world. This is you can now see 12 of 16 carbon ion facilities are existing in Asian countries. And this slide shows current indications for carbon ion radiotherapies. 2022, 5 diseases became covered by Japanese National Health Insurance. Hepatocellular carcinoma is covered by Japanese health insurance for difficult to resection cases of 4 centimeter or larger tumor size. Okay, I'd like to introduce our carbon therapy for hepatocellular carcinoma. Treatment for hepatocellular carcinoma is well documented in various guidelines. So where exactly should we consider particle therapy? The answer to that is where RFA and surgical resection are not optimal. Both RFA and surgical resection have exceptional outcomes. So those who can be treated with RFA or resection should be treated by them. Our target would be those unfit for resection and with few enough nodules so we can spare the liver, but too large or too close to major vascular branches for optimal RFA treatment. So generally, we are talking with these patients. And stereotactic body radiation therapy is a great treatment modality. It's based on established techniques using lineacs, which you can find anywhere. But it has its limits. Tumor position in the center of the liver with rather large diameter are going to be quite challenging with SBRT. Using carbon therapy, treating these tumors are very easy, with 30 to 50% reduction in V20 gray and 30 gray, where it means the most. So these are the indications of carbohydrate therapy for hepatocellular carcinoma. No distant metastasis are difficult to receive other curative treatments such as resection, RFA, etc. And carbon iron therapy is no limitations of tumor size. Limitation of proximity to the gastrointestinal tract is also exists. However, in our facilities, we can be treated with 0.5 to 1 centimeter distance between tumor and gastrointestine. Okay, I talk about the clinical outcomes of carbohydrate therapies. We analyzed hepatocellular carcinoma treated with in our hospital over a 20-year period to confirm the efficacy of carbohydrate therapies. Cases with tumor diameter greater than 4 centimeters and 3 or fewer lesions were included in this study. And this is patient characteristics. 187 cases were included in this study. Due to the historical background, many hepatocellular carcinomas are caused by viral hepatitis. But the number of non-viral cases has been increasing in recent years. The median tumor size is 5.1 centimeter, including giant tumors that exceeded 10 centimeter. About 1/3 of the cases showed major vascular invasion. This is clinical results. The two blue line shows local control rate and red line shows overall survival rate. 2-year local control rate is 87% and the overall survival rate is 68%. And with a median survival time of 44.4 months. I think which is considered a good result. And this slide shows acute and late toxicities. Adverse events of grade 3 were observed in only 5 patients, and no adverse events of grade 4 or higher were observed. So, what are good candidates for hepatocellular carcinoma by carbohydrate therapy? We consider such subjects to be a particularly good candidate for carbohydrate therapies. The first is bulky case of hepatocellular carcinoma. This is a risk factor analysis for overall survival rate is previous studies. The multiplicative analysis of risk factors related to overall survival revealed that pre-treatment liver functions and initial primary treatment or recurrence treatment. On the other hand, there was a 10-to-1 difference in tumor size between small size and large size, but the difference was not significant. This is a comparison of treatment results between small size 4 to 5 centimeter case and over larger than 5 centimeter cases. Also, the small tumors tends to be slightly better, but the difference is not significant, indicating that even tumor larger than 5 centimeter can be adequately controlled locally and show good results. Blue line is a small size, red line shows a large size. And these are comparison with other modalities. Carbohydrate therapy is basically for cases that are difficult to resection or RFA. So the results are slightly lower than those of resection. However, when compared to TACE, the standard treatment for unresectable patients, the results are superior to carbohydrate therapies. like here. And I would like to introduce one case. This is a very impressive case. The patient was an 85-year-old male with an 13 centimeter giant tumor on the background of type C viral cirrhosis, liver cirrhosis. Liver function was relatively good, but this was a case of a very large tumor spanning both lobes of the liver. A surgery was considered for this case, but carbon therapy was chosen because of the small residual liver volume and the patient's age. This is in this case, 60 gray in 4 fraction of carbon therapy was performed for 4 days in this manner. And this is the MRI images 3 months later shows this MRI image showed rapid shrinkage of the tumor as shown here. And we also observed signal change on MRI consistent with irradiated field. As shown here, early shrinkage is observed after carbohydrate therapies. And this is images 2 years after carbohydrate therapy. As you can see, the normal liver in the irradiated area has atrophied and the tumor has completely disappeared. So it is expected to be a new option for curative treatment of large tumors that are difficult to treat with standard therapies, as it is highly effective. Okay, next target is major vascular invasion case. This is the same analysis of the risk factors analysis. It is very interesting to notice that the risk factor analysis for carbohydrate therapy shows that the major vascular invasions, which is an important risk factor as a therapies, but this analysis shows not a risk factors. Yes, everyone, you can also case of major vascular invasions are basically indicated for drug therapy according to the BCLC guidelines. Major vascular invasion itself is a poor prognostic factor and a component of staging. According to Japanese guidelines, surgical resection is indicated for cases in which surgical resection is possible. It has been reported that there is a significant difference in outcome between cases in which surgical resection is possible and those in which surgical resection is not. So, therefore, we have been treating cases of unresectable major vascular invasion with the potential for carbohydrate therapy to become a treatment option. So, this is a comparison of treatment results between major vascular invasion case and no major vascular invasion case. Blue line shows no major vascular invasion case, and red line shows major vascular invasion case. So, the both local control and overall survival rates were almost similar, with no significant differences. Of course, the background is completely different. So, this comparison is not so good. But I think the carbohydrate therapy is one treatment options for cases in which surgical is not possible. Okay, third target is low liver function cases. This is other studies in your facilities. We analyze the hepatocellular carcinoma case in low child pure B, low liver function cases. This case, including the tumor sizes, all tumor sizes. And this is the patient characteristics. The most of case in child Pew score is 7, but 35% of cases are 8 or 9. And due to the recurrent nature of hepatocellular carcinoma in the liver, we have experienced many cases in which the liver function gradually deteriorated after repeated treatment with surgical resection, RFA, TACE, etc. So the majority of patients are referred to our hospital for carbon therapy because to the difficult in receiving standard treatment for recurrence in the state of decreased liver function. So 80% of cases are recurrent cases, and most of cases are after liver resection. This is clinical outcomes and the change of child Pew scores. This is before carbohydrate therapy. This is after carbohydrate therapies. In acute phase, 24% of cases decrease child Pew scores, and late phase is 40% case decrease child Pew scores. Overall, child Pew score tends to worsen, but this is thought to include not only the effects of irradiation, but also the worsening of the original cirrhosis. And this slide shows the overall survival rate and progression-free survival rate and local control rate. Carbohydrate therapy may be an appropriate treatment modality for hepatocellular carcinoma with poor background liver. However, looking at the results divided by child Pew score 7, 8, 9, we consider that the indication for carbohydrate therapy should be cautioned, since the majority of cases with a score of 9 do not achieve long-term survival. So our treatment, our target is child Pew score 7 and 8 only. And in addition, there was no difference between patients whose child Pew score worsened and those whose child Pew score did not worsen in the acute stage compared to those whose child Pew score worsened in the late stages. On the other hand, patients who worsened in the late stage had a significantly poor prognosis. Okay, I would like to introduce one case. This is a very difficult case. This case is 60 years male NASH, and first carbohydrate therapy is child Pew score is 8B. Very poor liver functions. And this is first HCC, and we treated the 60 grade 4 fractions in this manner. And after that, he developed the second HCC in here. And this case, child Pew score is 8B. So we treated next carbohydrate therapy, or same dose and fractions. But this case is, this slide shows the change of liver functions. Before first carbohydrate therapy is 8B, and after 1 month and 1 year after first carbohydrate therapy is little bit worsened to liver function, but liver function is recovered just before second carbohydrate therapy, 1.5 years after first carbohydrate therapy. This case, so we treat the second carbohydrate therapy, but 3 months after second carbonized therapies is he developed the child P-score is 9B and the, new lesions in intrahepatic region. So he did not receive another carbonized therapy, and he chose the best supportive care. And after 1.5 years, he died low liver functions. So the low liver function case is very good candidate, but repeated treatment is very careful treatment. So we select the location and the liver function and the patient characteristics, etc. Okay, this is a summary here. Carbonized therapy is a promising new treatment option for hepatocellular carcinoma. Carbonized therapy will be an effective option for large tumors, major vascular invasions, and low liver functions. So in Asian countries, we have many plans to the carbon facilities. So I'm very expected to the new era of hepatocellular carcinoma treatment. Thank you. Okay. Okay.
Thank you, Dr. Wakatsuki, for excellent presentation. My name is Oki from Shioda Memorial Hospital. I am one of the discussants, so I have a question for you. So could you tell me the best candidate of heavy particle beams in case of a single large HCC with portal vein tumor thrombosis? Because in such cases, we can Japanese guideline recommended atezolizumab and bevacizumab therapy as a first line. So how do you think?
Yeah, I think this is a very good candidate for our treatment. So yeah, I hope to including the Japanese guidelines in carbon therapy.
In my opinion, if the tumor burden is life-threatening, I think it is better to choose heavy particle beam because the effectiveness of chemotherapy is not so high compared to heavy particle beam.
Yeah, if possible, I want to the combination therapy for carbon ion and ICI. Yeah.
Thank you.
Okay. Do you have any question or comment from the audience? Yes, please.
So, Dr. Park from Samsung Medical Center, Korea. I know that in Japan there are many particle therapy facilities. Maybe some hospital have the carbon and proton therapy together, and some hospital have only proton therapy or carbon ion therapy. So, do you have any idea that comparing the carbon and proton, what's the point to select the better treatment between carbon and proton therapy?
Yeah, it is my opinion. So the core hepatocellular carcinoma, proton and carbon is almost similar results, I think. But only the close to the gastrointestinal case is better for the carbon is better than protons because hepatocellular carcinoma is not radio-resistant tumor, I think. So both is okay, I think. Do you have any questions? Okay, let's move to the second speakers. Second speaker is Dr. Doi from Hiroshima Prefecture Hospital in Japan. Her title is The Role and Future of Stereotactic Body Radiotherapy for Hepatocellular Carcinoma. Dr. Doi, please.
Thank you. My name is Yoshiko Doi. I'm a radiation oncologist using X-ray. I am very honored to speak about SBRT for HCC. I don't have COI. Radiotherapy machine and treatment planning device are very advanced. This photo is my hospital radiotherapy machine. Several supporting devices provide accurate image guidance and respiratory motion. And this machine produces much higher dose in a shorter time. Computer performance and treatment planning algorithm are improved. So you can see that SBRT combined IMRT increase flexibility for SBRT, so you can avoid stomach and duodenum. Compared to the past, SBRT is higher dose, more accurate, and more safe. SBRT has often been used in lung cancer. This case is 80-year-old man who refused surgery. We performed this lung cancer SBRT, 42 gray per 4 fraction. 6 months later, lung cancer had disappeared and there were no adverse events. This shows a prospective trial with specified comparison to BATS and SBRT for lung cancer. There was no significant difference between BATS and SBRT in cancer-specific survival and in overall survival, and fewer adverse events at SBRT. So SBRT has established therapeutic efficacy in lung cancer, then increasingly applied SBRT to other diseases. Combined with the increasing precision of radiotherapy machine, the number of institutes and cases using SBRT is increasing every year. The number of lung cancer cases is particularly high, followed by HCC cases. I would like to talk about the presentation of SBRT eligible case, evidence and consensus-based guideline, and then the future of SBRT. First of all, I introduce the characteristic case. 78-year-old man, he had solitary 3 cm HCC, suspicion of abutting right hepatic vein. He had HBV carrier, liver cirrhosis, history of cerebral infarction, and anticoagulant therapy. Which treatment option do you prefer? As you know, the BCLC guideline shows that resection, ablation, and TAC are indicated for small HCC. So his doctor proposed TACE because he is unfit for lobectomy. The tumor is not applicable for RFA. He is on anticoagulant therapy and TACE recommended in guideline. But do you know SBRT is effective for this situation? As a result, he refused TACE and decided to undergo SBRT. I would like to briefly introduce the method of SBRT of my hospital. My hospital performed SBRT under voluntary breath hold. As a preparation, for only 1 day patient need for a treatment planning CT scan. 3 to 5 days for treatment planning and verification, and 4 days at actual treatment, which takes about 30 minutes per day, 40 gray per 4 fraction. You can see that SBRT was performed on this HCC, 40 gray per 4 fraction, and 3 months later, this tumor had disappeared and there was no treatment-related adverse events. This summarizes SBRT preferable situation. For unsuitability for resection or RFA, size is 5 cm or less, number is 3 nodules or less. Tumor location is just below the diaphragm, liver surface, near vasculature, and tumor invisibility by US. Patient condition is obesity, bleeding tendency, and under dialysis. Diffuse RFA and resection or relapse after RFA, TSCE, and resection are also preferred situations. A specific case will be presented. As you can see, RFA has a risk of insufficient result, whereas SBRT is easy to administer and has sufficient results. Furthermore, it is characterized that radiotherapy is less toxic. Treatment can be provided at an outpatient clinic. No pain is associated with treatment. Few serious side effects have been reported. Even elderly people can receive SBRT without difficulty. In addition, repeated SBRT is also safety. This study examines the result of the first and second SBRT efficacy and adverse events. In results, the frequency of local recurrence is similar for after first and second, and there were no difference of the frequency of grade 3 toxicity. The author concluded that repeated SBRT could be safely applied and results in high local control rate. Check the evidence and consensus-based guideline for HCC. And look at the BCH guideline again. Although the choice of treatment option depends on the progression, HCC, radiotherapy is not listed as a treatment option. Japanese guidelines selected treatment based on liver function, extrahepatic spread, vascular invasion, and number and size. Unfortunately, radiotherapy is not listed as a treatment option in this guideline either. Why is there no radiotherapy? Because extra-beam radiation has a low level of evidence, so concluded strongly not recommend. Evidence is like a king that is very strong and hard to break down. But I would like to emphasize that SBRT is also a good treatment. One of the outcomes of SBRT is presented. This study is a result of a multi-center analysis in Japan. Eligibility criteria is previously untreated initial HCC, 3 nodule or less and 50 mm or less, child pool class A or B, and unsuitability for or refusal of standard treatment, and Jacob Member Hospital conducted 2013 to 2017. 73 patients with 79 lesions are included in this study. The median age was 77-year-old and median follow-up period 45 months. With very low local recurrence rate, about almost 9% at 3 years, and overall survival rate of almost 70% at 3 years. When meet general dose constraint at institution familiar with SBRT, The incidence was very low for treatment-related toxicity, liver dermatitis, pneumonitis, liver failure, ulcer, bile duct stenosis, portal vein thrombosis. So SBRT is a promising treatment modality, particularly for small HCCs, as they are not suitable for standard treatment. There are several reports of SBRT outcome. Although the type of study, previous treatment varied, the local control rate were uniformly high. In a meta-analysis recently submitted to leading journal in the field of radiation therapy, which summarized the outcome of SBRT using 70 studies from the database, the pooled 5-year local control was 82% and grade 3 or higher hepatic toxicity was only 4%. Trials are also being conducted on de novo HCC to confirm oncologic efficacy of SBRT. This is the multi-center prospective phase 2 trial in Japan. Patient eligibility was untreated HCC, child pool score under 7, 5 centimeter or less, and lack of suitability for or refusal or surgery or RFA. Local progression-free survival was 90% at 3 years, and overall survival rate and 78% at 3 years. The promising result indicates that SBRT may be an alternative option in the management of early HCC. Comparing with the other modality for outcome for de novo HCC, the median age for surgery and RFA is in the 50 to 60 range, and the overall survival rate is almost 70% at 5 years. On the other hand, SBRT elderly 70 the median age for SBRT is in the 70s and about 70% at 3 years. Although SBRT is intended for elderly patients, the survival rate after SBRT is not low. So, surgery and RFA have high local control, good outcome, high evidence. However, SBRT can also be recommended as an effective treatment. In particular, I would like to mention about each has its advantage between RFA and SBRT. Each has its advantage and disadvantage. However, treatment efficacy may be equivalent between RFA and SBRT. Here are the results of a comparative study of SBRT and RFA in propensity score matched cohorts. This is a single center study in Japan. SBRT and RFA have similar overall survival rate after propensity score matching. This study is multi-center in nature, and SBRT and RFA have similar cumulative incidence of death after propensity score matching. In a meta-analysis of studies rated as high quality, the concluded that SBRT can achieve similar local control and overall survival as RFA. This study is RFA versus proton, not X-ray, but this is the first study to compare prospectively the therapeutic efficacy of RFA versus proton for small HCC. There were no difference between RFA and proton in local progression-free survival and overall survival, which are based on these studies. According to the 2022 ASTRO Clinical Practice Guideline, radiotherapy is strongly recommended as a potential first-line single option for patients with HCC who are not candidates for curative standard treatment and for whom TACE is being considered, even if the quality of evidence is not high. And also in the latest edition of the NCCN guideline, radiotherapy is one of the local treatment options for patients for whom resection is not indicated. In BCHG guideline, due to lack of evidence, radiotherapy cannot be recommended. On the other hand, in ASTRO NCCN guideline, evidence is lacking, but radiotherapy can be recommended. Although clinical guidelines are not consistent worldwide, there is a growing voice that SBRT is an effective treatment. How do we respond in Asia? I think it would be good to establish guidelines that SBRT can be recommended. Finally, I would like to talk about the future of SBRT for HCC. We radiation oncologists, every effort should be made to increase the level of evidence for SBRT for HCC. Specifically, establishment of a nationwide clinical database of SBRT for HCC, and to explore the possibility of randomized clinical trial comparing SBRT with other treatment modality and combination of SBRT with new immunocheckpoint inhibitor. According to the clinical trial government, this is United Clinical Trial Database. Two phase 3 trials have been enrolled, but neither of which has yielded the result yet. If these studies are completed, the result may provide important evidence to be considered in the clinical guidelines for HCC. And there are several ongoing studies about combination of SBRT and immunotherapy. SBRT may augment immunotherapy through its immunomodulatory effects. The next speaker, Dr. Park, will discuss in the result. To improve prognosis for HCC, SBRT can be combined with other modality. SBRT will not replace other modality. SBRT may help other modality. When considering RFA resection TACE, SBRT is also one of the effective treatment modalities, so please remember that SBRT may be helpful in difficult situations. Here is a summary. SBRT for a small HCC less than 3 in number and less than 5 cm can be safely performed with high local control. SBRT is well recommended for small HCC cases when standard treatment are not feasible if liver function is childhood A or B. Benefits of SBRT could be evaluated by liver surgeon and hepatologists in their daily clinical practice. I would like to thank conference chair Dr. Shina and Dr. Omata for the opportunity to make a presentation. Thank you for your attention.
Thank you, Dr. Doi. Could you please comment from?
Thank you for your excellent presentation. So I have a question during your presentation. So how many times can we safely treat HCC by using SBRT without worsening liver function. You presented that for 2 times we can safely apply SBRT, but as you know, the recurrence rate of HCC is very high, so we sometimes perform radiofrequency ablation for 3 times, 4 times, or 5 times, or much more. So could you tell me your opinion?
Yeah, in clinical, I have 6 times repeated SBRT, one patient, but liver function under child pool score 7, you can SBRT repeated, yeah, more to more silver. And but long time liver function is maybe damage long term due to low dose irradiation. So
Can I comment on that? Actually, we don't have many studies to compare the RB grade checkup repeatedly after SBRT or RFA. There are no comparison. But in my thinking, I did a lot of preliminary study on that. Actually, even with the particle therapy, it's not like the RFA compared to RFA. So if RFA can be done, RFA is definitely preferred condition. And if not, actually the local control is also important. So if it cannot be controlled locally, then the future is, not deserves to spare the normal liver. So I think RFA, there are some studies that in very cirrhotic patient after RFA and SBRT and the TAs, even with TAs, there was some decline of clinical liver function. But the only treatment without any decline in very cirrhotic patient was RFA. So if it can be ablated, RFA is better, and as alternative treatment, SBRT is an excellent alternative option.
Yeah. Thank you for your comment.
Thank you.
Do you have any comment or question from audience? Okay, thank you, Dr. Doi. Okay, next speaker. Next is Dr. Park from Samsung Medical Center. His title is Experiments in Clinical Trials Combining Immunotherapy and Radiotherapy. Dr. Park, please.
Thank you, Chairman, for the introduction. And today I'm going to present the experience of combining immunotherapy and radiation therapy, especially for HCC. I have no disclosure. For HCC management, radiotherapy can be used for alternative modality for ablation or consolidation of intra-arterial therapy such as TAs, and as a combined modality for advanced disease. Before, radiotherapy was not frequently used for HCC management. However, recently, due to the accumulation of evidences, radiotherapy is tried more frequently than before. And in 2022, Korean Liver Cancer Association guideline, radiotherapy is considered as one of the best option and alternative option, depending on the stage as a sole modality or in the form of combined modality. In HCC management, actually, the multimodality approach is very important. This slide shows that the multidisciplinary therapy approach gave the additional value, especially in patients with poor liver function and in patients with more advanced disease such as BCLs B or C. Our Liver Cancer Center HCC registry shows that radiotherapy is more frequently applied along the period, and especially radiation is more frequently applied as initial management. Depending on the cohort period, radiation use rate is rapidly increasing in recent cohort patients. Also, in an elderly patient, already Dr. Doi touched on that. In elderly patient, some conventional treatment is not possible. So in that cases, there are more and more consulted for the radiation therapy as an alternative treatment option, and radiation is being even used more frequently as a curative modality. After introduction of proton beam therapy in our facility, proton therapy is rapidly replacing the conventional X-ray radiotherapy, and also the radiation is used for more early stage disease such as BCLC 0 and A more frequently with radiation. However, in the management of HCC, we discussed it just before. The hepatologist's concern is on the preservation of liver function, and they need to spare the surrounding normal liver for a rainy day, actually, which means for the case the patient will have the recurrent disease in the liver in the future. So then how could we spare more normal liver while applying the radiation? One is a physics-based approach, which means the application of more advanced radiation technology such as IMRT and proton beam therapy and carbon ion beam therapy. And the other approach is biology-based one to reduce the prescribed dose in combination with various radiosensitizers. So you can see here that you all know that proton therapy, carbon ion beam therapy will spare more surrounding normal liver. And in our some experimental work, even with proton therapy, radiosensitizers such as HDAC inhibitor sensitize the radiation they're killing. And the proton RBE is normally considered as 1.1 compared to X-ray radiation therapy. However, in our experimental work, we could find that in vitro and in vivo condition, the RBE of a proton can be increased, giving a potential to decrease the prescribed dose with even with particle therapy. And most hot item is the radioimmunotherapy. In our experiment, we could find that the combination with the immune checkpoint inhibitor and radiation enhanced the therapeutic effect on irradiate site and non-irradiate site also. So this was the so-called abscopal effect. It was through the enhanced T-cell activation. So one of the key questions is that the standard systemic therapy for advanced HCC and radiation can be combined safely in patients. In our liver cancer cohort, we could find that TKIs, including sorafenib and lenvatinib, which is the just before the current standard therapy, and radiation can be combined and improve the patient's survival and progression-free survival. So now the current standard for advanced HCC is the combination with atezolizumab and bevacizumab. One is immune checkpoint inhibitor, and the other is anti-angiogenic agent, and there are some biological evidence that even with that combined drug therapies, radiation can provide the additional synergy. There are some biological evidence that the marriage between radiation and those combined systemic therapy. One of the interesting findings we have found in our cohort is that radiation can improve the patient outcome regardless of the timing of radiation application. As you can see here, that with the concurrent use with nivolumab and radiation, and without any combination of radiation therapy, just the history of radiotherapy improved the nivolumab therapy effect. And this graph shows that even it doesn't matter that the location of radiation therapy is liver directed or just for bone mets and other soft tissue metastasis. There are also the synergism between radiotherapy and systemic immunotherapy. So it is the result of the conjoint effort with my institution and National Cancer Center Korea in patient with advanced HCC, patient with far advanced vascular invasion. Among 50 patients, 23 patients, 25 patient was more than PP3 and 4, and some patient combined with hepatic vein tumor thrombosis, and in this patient, combination of nivolumab and radiotherapy was tried in phase 2 prospective trial manner, and trial resulted quite impressive outcome with 74% of disease control rate and 5.6 months progression-free survival. This is the same slide, and more interesting thing in the subgroup analysis was that compared to X-ray, proton therapy patient gave more excellent median progression-free survival. So I don't know what is the background that with the same agent immunotherapy combination, why the proton gave more the improved survival than X-ray radiotherapy. So there are some clue that if with proton beam therapy we can spare more lymphatic organs such as spleen and lymph node area, that can be one clue. But on the other hand, there are some experimental studies with very low dose irradiation to the bowel improved the radiation therapy result in European countries. So I don't know what is the real answer in the basement of this phenomenon. So the future trial to reveal the mechanism between the synergism with the particle beam therapy and immunotherapy. I have some interest on that, and also in patients with more good liver function and without sarcopenia, there are more synergism between immunotherapy and radiation therapy. As you can see here, our trial result disease control rate was 74%. However, current standard therapy, atezolizumab, bevacizumab, the number was 74%, exactly same. So what I'm curious is if we add the radiation therapy on the atezo bevacizumab standard therapy, what will happen? So now I am running the new prospective trial which combine atezo-bev with the proton beam therapy about the safety and the efficacy. And if it is successful, I expect we can expect the study to phase 3 trial manner. And I just started the accrual last year, and the accrual is very smooth, and already more than 30 patients was accrued, and in the clinic, it's giving quite good impression. So this patient is the number 2 patient in the trial, and the HCC with far advanced vascular invasion. With the standard atezo-bev combination, the proton therapy was added in daily 10 gray fractions for 5 days. And with combination of proton beam therapy, tumor marker was normalized and giving sustained tumor response without extrahepatic spread. You can see that even with actually proton beam therapy was added between second cycle and third cycle atezo-bev. Even with first cycle and second cycle, the tumor marker tended to increase, and just after the proton beam therapy, the tumor marker decreased dramatically, just immediately after the radiation. And I like to propose one more thing, that is, while we are trying to combine radiation therapy with the systemic therapy, actually not interfering the course of systemic therapy is also one of the major components for the successful combined therapy. So recently, there are emerging concept of ultra hypofractionated radiotherapy in the radiation oncology field. I just, as a pilot, I'm trying to combine radiation intermittently in between the systemic therapy cycles of immunotherapy. So this is the very huge tumor example, and the intermittent just 8 gray per 1 fraction was applied between the immunotherapy cycles. And here's also they shown a very good result just with the 50 gray 5 times proton therapy patient. So I think to develop more well-designed clinical trial will be very interesting. So in conclusion, multimodality approach to manage HCC is important, and especially for patients with advanced disease with vascular invasion or poor liver function. And definitely radiation can be combined with the systemic therapy, and I believe that it definitely deserves that try not only combining various systemic agents, but also the combination of systemic therapy and radiation therapy together. Thank you very much for your kind attention.
Thank you, Dr. Park. Please comment.
Thank you for your beautiful presentation. So do you have any data or experience that the combination of radiation and the immunotherapy increase the frequency of abscopal effect? Because in my experience, in real clinical settings, the abscopal effect is very rare. So if we can deliver abscopal effect by using the combination therapy, I think it is very promising.
Yeah, abscopal effect is actually, I have some cases, but we don't know that without radiation therapy, the patient could, destined to decrease in everywhere. So with atezo-bev, there are still some complete response cases. So in one case, we cannot say that. However, abscopal effect, in each case, it is, as you told, it is very rare to complete remission in the irradiated site and unirradiated site also. But as we see the irradiated site progression-free survivor and unirradiated site progression-free survivor, there are definitely difference. If we add the radiation in the unirradiated site with systemic therapy, there are difference of the disease control rate and the progression-free survival. So the phenomenon exists, but it cannot be revealed in a dramatic manner.
Okay, please.
Hi, I'm Landon from the Chinese University of Hong Kong. So I just want to ask a quick question that do we have an idea of the most optimal dose and fractionation for radiotherapy in order to combine with immunotherapy? Because the lymphocytes are very sensitive to radiation, and we want the lymphocytes to work with immunotherapy to tackle the cancer. But we are giving very large doses of radiation to the body, and of course, also the low dose field will also kill the lymphocytes. So I just wonder, what is your opinion on that? Thank you.
It's a very excellent question. Actually, we all know the 4 R's.
Yes.
Yeah. So if the delivered dose is sublethal, then there are kind of NF-kappa B and the VEGF research. So actually, at least the tumor should not be sublethal. So the reason why I selected the A-gray in my case is, at least in the where we are treating bone mets, there are some response with A-gray palliative therapy. So the minimum I thought the A-gray I need, and there are some experimental evidence that if the fractional size is too high, then there are some Tregs related, biological mechanism, and all the neoantigens eliminated. So that should be in between, should be more than A-gray and less than maybe SBRT dose while we are combining the immunotherapy. And the other component is our heart is continuously working, and in the irradiate there are so many blood vessels, and if the heart is pumping, and it acts as a blood irradiator actually. So the dose rate dependency there are. So if the dose rate is high, then it's good to combine with immunotherapy. So in that sense, the flash radiation therapy, I don't know, it could be in the clinic in near future. Maybe I expect that if the flash radiation therapy is in the clinic, I will retire already. But I think with the very high dose rate radiation in a modest hypofractionation, and let's just forget the 4R, then in between, not interfering the systemic therapy, there will be some optimal treatment strategy, but I don't have any concrete answer at this time.
Thank you very much.
That's okay.
Good afternoon. Hi, I'm Natalie from Hong Kong. I'm a radiation clinical oncologist. Thank you very much for an excellent talk. I also have a bit of a question on the RT dosing, because I noticed in your Nextra trial that you use a 10 fraction based regime. So just wondering how you select this regime, and because, for example, in SBRT, then now we're moving towards more hypofractionated regimes in terms of maybe 5 fraction based. And I'm just wondering, for your subgroup analysis, you've shown that the proton beam therapies had seem to have a better outcome. So I'm just wondering, for these patients receiving the proton beam therapies, are they using the same 10 fraction based regime, or is it a more hypofractionated, and whether there would be any factors that could affect the outcome as well? Thank you.
Yeah. Actually, that is also a great question. Before, our conventional fractionation regimen with the proton therapy and X-ray radiotherapy is 10 times in 2 weeks, just increasing the fraction size depending on the irradiated river volume. Before, while I'm being trained, we just fixed the fraction size and then increased the number of treatment. Then it made the dose escalation. But recently, we just fixed the treatment number and increased the fraction size, daily size. That is the current practice in our institution. So because my standard fractionation was 10 times in 2 weeks, and starting from 3 gray daily fraction up to 6 gray. So it makes 30 gray to 60 gray in 10 fraction. But in the nivolumab trial, the dosing interval was 2 weeks with nivolumab. So I felt quite some, technical difficulty to visit the medical oncology department simultaneously to the radiation oncology department in some day. So I felt some difficulty. So in our trial, just combining proton therapy with the Ateveb, then I just reduced the fraction number into 5 days. Then Ateveb is a 3-week interval. So in the, the vacation period in between, I can safely deliver the radiation. And then there are another very important issue while combining immunotherapy and the radiation therapy. The before is better or concurrent is better, and just augmenting the systemic therapy is better. We don't have any concrete answer, but theoretically, if we do irradiate, then there are some neoantigen release and dendritic cell activated. Then if the immune checkpoint inhibitor goes, that will be theoretically perfect regimen. So radiation first and systemic therapy just after is the perfect answer. However, practically in the clinic, we also have a very long waiting list in the radiation oncology department. So in our facility, actually, medical oncology, the systemic therapy dosing was the booking is earlier than radiation therapy, so we just decided to do the systemic therapy first, and in between radiation therapy, and after that, just continuing the immunotherapy until 2 years. That was our strategy. So now I'm just like to not interfering the systemic therapy department's practice in combination with radiation therapy.
Thank you.
Okay, last question.
Thank you very much for your presentation, Professor Park. I'm Dr. Rim from Korea University. My question is about the combination of radiation and atezolizumab bevacizumab. The first one is because of the very rapid response compared to our previous experience. There are some opinions that we need to normally we try to elevate the dose as long as the normal constraint is fine, but there are some opinions that we should reduce the dose because of its too rapid response. And I'm curious about your opinion about that dose optimization. And the second experience is in my clinical experience when they're using atezolizumab bevacizumab, there are some kind of tendency the more bleeding risk of GI systems. And although we don't have evidence yet, but I want to have your clinical experience opinion. Thank you.
Yeah, very good question. And I'll answer about the second question first. And the dosing, nominally, I told that 50 gray, but we all know the radiation constraint for the normal, especially stomach and duodenum. So I used the simultaneous integrate boost technique. So I definitely reduced the dose going to the GI organ. So I didn't experience the serious GI problem, but there are many evidence in lung cancer and the pelvic organs. There are some synergism to produce the bleeding in combination with Avastin and radiation therapy. So I'm just strictly managing my dose constraint on that. And before come to this accruing this trial, normally I just do the fibroscope first, and if there's some Varix, then the Varix treatment first, and then accrue the patient to the trial. And the optimal dosing and the speed of the expected tumor response, I don't have any very good answer on that, but maybe if the treatment schema takes 1 or 2 weeks, just in between taking the field checking CT scan again will be very good answer. But with the 3 or 5 fractions, that is, very impractical. But, modern radiotherapy machine have a very good COMBIM CT integrated in the system. So the image quality is not that high, but roughly if the physician attend the treatment session, then we can see there are so unexpected dramatic tumor response, then we can replan the patient in that situation.
Do you have any question, comment? We have much more time because one speaker is cancerous. Okay. Okay. Thank you, Dr. Park.
Thank you for attention.
Yeah, this concluded this sessions. Thank you for everyone's cooperation.
Thank you very much, speakers and moderator. The last session will start at 5:10 p.m.